Anybody familiar with CPAP, BIPAP, AutoPAP, all that good stuff? Alrighty, well, I'm going to explain the difference of those three. We're going to state the purpose of PAP devices, what causes airway obstruction, identify some issues around patients that are being non-compliant, provide corrective actions for CPAP, BIPAP, AutoPAP use, and cleaning of BIPAP, CPAP, AutoPAP units. And also state what a proper physician order shall include. All right, so I'm going to start reversed here. I'm going to start with CPAP. So CPAP is continuous positive airway pressure, and the best way I can explain that is, this is me, I'm sitting in my car, I'm doing 60 miles an hour. I put my window down, I stick my head out, and I breathe in and out against that 60 miles an hour. It can be a challenge for some patients, especially if their pressure is 14 or 16 or whatever. That's a bunch of air blowing in your face. Okay, so you understand CPAP. BIPAP. Okay, take the same scenario. I inhale, I'm doing 60. I'm going to hit my brakes to exhale. Make it a little bit easier. So I have an inhalation pressure and I have an exhalation pressure. Typically it's going to be like 16/8 or something like that. The reason I go into great details explaining this, if a doctor writes the order and says BIPAP 12, that's not BIPAP 12, that's CPAP. No, it's not. You know, we've get in that discussion many times sometimes. Anyway, CPAP is one number, 5, 8, 12, whatever. Typically, they're never going to write you for anything over 20. If we're over 20, we're probably on a ventilator, okay? Your home devices won't go over 20, so 20 is max. So you're going to have CPAP, you're just going to have one pressure. BIPAP, you're going to have two pressures. And they may vary considerably. I mean, it may go from 5 to 20. Or typically, if it's 8 for EPAP, it's probably going to be 14 or 16 for IPAP. Okay, there's usually 5, 6, 7, 8% what we call driving force, which is the difference between those two. So for this slide, we've got BIPAP. We understand that it's two numbers. CPAP is one number. And then AutoPAP. So how AutoPAP works is the physician is going to write you a range. So we're going to set the device at, normally it's like 5 to 20 or 5 to 18. So what we set the range when the patient wears their mask and they go to sleep, when you first lay your head down, you usually need 5, 6, 7, maybe 8 low. And then as you get into deeper sleep and everything starts relaxing and everything starts closing up, then the machine says, oh, you need more pressure. So 2 or 3 hours into your sleep, you may have went from 5 to 16, but you're asleep. Your body is loving it because it's getting recharged. And all of this is happening without you knowing it. I will point this out right now. You may have a patient in here that has AutoPAP, and they wake up in the middle of the night and they start fussing because this thing is blowing. You have to remember, this is a machine. If they wake up out of a sudden dead sleep because of a crack of lightning or something, you got to remember this machine thinks they're still fast asleep. So if it was at 16, it's still at 16. And now they're going to try to put that back on and they're going to be calling you. Because it's blowing too hard. I can't get it on. That ain't working. And that happens all the time. I've gotten many phone calls for that. Just cut the machine off. Give it 30 seconds. Cut it back on. And it's going to recycle again. It's going to start way down here. It's going to let them fall back to sleep. And then it'll ramp back up to whatever it needed to be. Okay, so just put that in your hat, and you'll probably need it in the future if you have any AutoPAPs come in. Again, they're going to set us, the doctor's going to write us a range on that. Here are a few of the devices. I think all but one of those now is a Philips Respironics, which have all been recalled and reworked and all that kind of stuff. So remember, you have three things. You have the CPAP, the AutoPAP, and the BIPAP. I'm going to go ahead, let's see, purposes of non-invasive. Okay, I'm going to go ahead and cover a couple of items on the mask. You're going to have patients, I'm sure you probably have several in here that wear their own, don't they? CPAPs or BiPAPs? Yeah. So just a couple of things I want to hit on, because you may run into this from time to time. But these masks, especially if they have full face or nasal masks, they have a little rubber seal. Some are foam, some are blue gel. I mean, there's all kinds out there on the market, but you're familiar with that. If this is ripped or has gotten a hole in it or something, it's not going to work right for the patient, okay? It needs to be fixed. And typically, like this one here, it just pops out. So whoever their provider of their mask is, let them know they need a new seal, okay? Because if it's not sealing properly, it's not working properly. That's one problem you may run into. Two, if it's a new patient and you're just now discovering that it's not sealing real good, well, if they wear dentures and they don't wear them at night when they put this on, you may have a multitude of difficulty. One, because there's no rigidity there, so then you'll start hearing flapping and all this other kind of stuff. So then it's just going to be a case of trying to get the right mask to fit that patient. You know, facial contours without their dentures in, okay? Again, this is a full face, covers the nose and the mouth. You've got nasal pillows, which just seat in the nares, and then you have just a nasal mask, which looks just like this, only it fits only over the nose. Another thing that you may run into are headgears. They're all different kinds of configurations, depending on what the mask and everything is. But normally, the wider part is going to go down at the base of the neck. Let me see if I can set this up. So the wider part is going to go down at the base of the neck. Oh, I forgot to introduce y'all. This is Bob. He gets to go everywhere with me, pretty much. So the wider part is going to be at the base of the neck, and usually this is going to come around and hook to the front of the mask. It may be on pegs like this one is. There may be magnetic snaps, other fancy kinds of little clips and what have you. But on your headgear, typically the wider part is going to go at the base of the neck, and you're going to have one strap go over the head. Okay, I've seen them twisted, turned, just a mess, and not on right, and the patient says, this doesn't feel right. No, probably not. They've got this around their neck, and it's just a mess. Okay, so try to look at it logically, and you're only going to have one piece go across the head. So therefore, I'm not going to put that on his head. I've seen it done. I'm going to put this down behind his neck. Okay? I point that out because it happens. They get so confused. Those things get twisted around, and I've had to go visit some little old ladies that, they had theirs tied up in a knot. Let's see. So let's see. Purpose of non-invasive ventilation. As such, with a
how often should
yes.
this be changed?
I'm sorry.
How often should we change change those, or how often should they?
Change. A lot of times, as far as the mask and everything goes, so cleaning wise, you're going to clean them daily. That should be a daily thing, wiping them out or whatever. The tube, same thing. I don't know what you'll use here in the facilities. In the home environment, we usually give them two options: a mild detergent and water, or white vinegar and water, 50-50. Most patients prefer that because they say if you use the detergent, they can still taste and smell it, and they don't like that. Usually it depends on the DME and I guess who their payer source is. All of our contracts are through the Department of Energy, Department of Labor, and so the government provides them new ones every 3 months. I mean, they don't even, once we have it in our system, it goes right straight to them. So I don't know what normal DMEs, do you?
No, I'm just wondering if there's like a manufacturer recommendation that has changed.
As far as the mask and everything like that goes, not really in changing, but in the cleaning process. Any other questions before I move on? No? So now we're going to start talking about tracheostomies. Let's see. Associated with CPAP, BIPAP. OSA, obstructive sleep apnea, is one of the more common causes for the need for CPAP or BIPAP. CSA, central sleep apnea, chronic respiratory failure, chronic obstructive pulmonary COPD, ALS, and post-respiratory failure or post-ventilator failure. Just real quick, a lot of folks don't realize that there's it's a mix of OSA or central sleep apnea. So central sleep apnea is a neurological condition, and so typically they're going to notice that when you have a sleep study done, but not all the time. And then you may have a patient, or I've had several patients over the years that they'll call me and say, my machine cut off in the middle of the night. A lot of these machines have auto on, auto off. You have to remember, it's a machine. If it's not something going in or out, it thinks we're done. Okay, so if they have central apnea, they actually stop breathing. The machine says, oh, he's up now, and cuts off. They call me, my machine's cutting off in the middle of the night. Usually we have to turn that feature off. Okay, they auto off, we turn it off. That way it won't shut off if it doesn't feel them kind of breathing. So, and you can have a combination. You can have what they call mixed sleep apnea, which is going to be a combination of obstructive, where the tissue is causing it, or you're going to have central, which is going to be neurological. That next slide kind of gives you a little bit of an overview of obstructive sleep apnea, where you'll see your airway should be open, but when you lay down and you start relaxing, that airway slowly closes up on the right-hand side. Persons with very large necks will almost inevitably have this problem, simply because of all that extra tissue and extra weight, so that when they lay down, it's starting to close up their airway. Again, a little bit more explanation into the OSA. So the application of PAP, positive airway pressure. So what it does is it pushes enough air into your airway that it keeps it patent. Okay, so so like for BIPAP, you're going to have one for inhalation, and you're going to have one for exhalation, rather than it just totally going away, because if it totally went away, then your airway would close. So some folks require BIPAP. AutoPAP does kind of the same thing. It regulates what you need in, and it also regulates what you need coming out on exhalation so that your airway stays patent. CPAP, which is why a lot of physicians have kind of gotten away from that, is again that one number. And if it's 11 and you're 3 hours into your sleep and you need 16, you're not getting it. You're getting 11. So that's a lot of physicians have gotten away from CPAP and moved into AutoPAP. So there's some of the compliance issues. All those on the right, you're going to hear them. You're going to hear one of those on a regular basis all the time. Leaks, we kind of already hit on that a little bit. Comfort, there are so many different types of interfaces out there. Again, I hit on a few of them earlier. This is a full face mask, covers the nose and the mouth. The nasal mask just covers the nose. Nasal pillows sit in the nares. And then they've got all kinds of variations from that. The Amara View is a rectangular shaped with an opening in the lining for the nose and an opening in the liner for the mouth. And it just kind of sits right there, so they really don't see as much of the mask with the Amara View versus a full face mask or something like that.
What about the ones that fit the full face?
In the last 12 years, we've only used one of those, and that was in the LTAC. I don't have any in homes.
Okay.
I have 321 respiratory patients in the...
I was just wondering, because I know they used them in the hospital.
Right. The LTAC was the last time I saw one of those. Yeah. And that was
Yeah, full face masks are really not preferred in this environment because with the presence of positive pressure, it causes gastric insufflation, which will cause what? Potential vomiting, right? So again, you vomit that mask, what's going to happen with that presence of positive pressure, you're going to aspirate.
Right.
So again, we try to avoid full face masks if we can avoid it.
Okay.
So that's why you're not going to see that full face mask. Even with these full face masks, we're using with caution because of gastric insufflation.
the last item on that list, too much airflow. That's common as well. Most all of your devices now have what they call a ramp feature. And so if you you set a ramp, what it will do is start at 4 and say they just laid down and everything and they need 8. It's gonna work its way up to 8. What we normally do is ask them, once they lay down, how long does it normally take them to kind of doze off? And so if they say 5 minutes or 10 minutes, what we'll do is set the ramp for that period of time. So the theory is they'll fall asleep before it gets up to the pressure they need. Let's see, compliance, corrective actions. Again, this is all very patient specific. It just kind of depends. There's the ramp, which we just talked about, the mask fittings, making sure we've got something that's comfortable for them. I mean, that's the key to the game. Chin straps. So if folks just use the nasal mask or the pillows and they sleep with their mouth open, that's useless. It's just going right back out. So we do have chin straps that we'll give them, and it reminds me of that old cartoon where that old lady's got that thing wrapped up around her head. Yeah. So let's see, additional humidification. So you've got all that air blowing in your face and it may dry you out. It's going to be very uncomfortable. You're not going to sleep very well at night. Most of your units have adjustments from 0 to 5. I only have 2 patients that have it off. That's unusual, but they have it turned off. They want the cold air. Nasal sprays, any of that other stuff. Let's see. We've already hit on care and cleaning. We touched on that a little bit ago about the mild detergent or white vinegar 50-50 with water. Wipe the masks. Your tubes, you're going to put some of it in there and slosh it around. Put your thumb on the end, slosh it around. In the home environment, we tell them to hang it over their shower curtain, until they get ready to go to bed that night. And that'll be all clean. Now there's new systems, SoClean and Lumen. SoClean, you actually have to have a special tank with a connection, and it is pulling moisture out of the humidification chamber on your unit and processing it through. The drawback now is all manufacturers of PAP devices will null and void their warranty if you use a SoClean on their unit, because you're introducing SoCleans to theirs, so they're not going to acknowledge their warranty. Now, Lumen is an ultraviolet process. You remove your tubing, your mask, the headgear, everything, and put it in the drawer. Close it, push the button, and when the light goes off, then it's done. It's a very good and effective unit as well. Let's see, physician's orders. So we kind of hit on this already as well. CPAP, the doctor's going to write one number, one pressure. BIPAP, the physician's going to write two numbers. You're going to have an inspiratory pressure, or IPAP, and you're going to have an expiratory pressure, EPAP. AutoPAP is going to be a range. In my experience, most of the times it's 5 to 20. Sometimes the 20 will vary, but most of the times it's 5 to 20. Ramp, we've explained that. Mask type, we've gone over most of those. Humidification, again, most folks are going to want that humidification, and most devices you can adjust it anywhere from 0 to 5. Normally we started at 3 on a new setup, and then we can tweak it from there for patient comfort. Hours of use per day. Sometimes the doctors will write QHS, and so if you tell the patient what QHS means, the only time they're going to wear that thing is at night. I'm telling you, it doesn't have to be at night. I've got patients that'll sit there watching television with their mask on. Why? Because it makes them feel better, and it makes it easier for them to breathe. So I've got one patient, he's having a really hard time getting used to it, and so he can only wear it for he's up to 3 hours now. But at the beginning, he says, I can only wear it for an hour. I'm not wasting my time. So you have to convince them 1 hour is better than 0 hours. And like I say, that was about a month and a half ago. Now he's up to 3 hours. He's gotten used to it. So you have to play the game with a lot of these folks. And it is a game of trying to get them to become compliant. Oxygen, the last item there was oxygen. Make sure you have a bleed in. It's going to be the same type of fitting usually that we had in this circuit here, and you're just going to put it at the tubing where it comes out of the humidification chamber on the unit. You'll attach this, and then you'll hook their tube to their mask, and you'll bleed in the oxygen. Now, a big thing with PAP devices and oxygen, you do want to monitor their SAT because all that air blowing and your oxygen coming in, we're diluting it again, remember? Okay, so in room air, they may be fine on 2 liters, may keep the SATs up there, but now when they lay down, go to sleep, and they got all this air blowing, it's diluting it down. So you may find, you may have to bump them up 1 liter or 2 while they're sleeping and on their PAP device.